In this seminar, we will talk about acute asthma in children. Asthma is the most common chronic disease affecting children worldwide. It affects 11 to 14% of all children and with increasing prevalence reported worldwide. The economic cost in the United States is about 726 million lost from parental work absence alone. Acute asthma exacerbations are associated with high morbidity and in rare occasions mortality. In US, 3 million asthma exacerbations reported in children less than 18 years in 2017 and 626,923 ED visits, almost 76,000 hospital admissions. Timely and appropriate management of acute asthma exacerbation is life-saving. In United Kingdom, 9.6% of UK population have asthma, 6.3 million primary care consultations, 93,000 hospitalizations, and 1,800 ICU admissions, and also 36,800 disability allowance claims. Asthma kills 3 people every day in UK. Every 10 seconds, someone has a potentially life-threatening attack. So in order to quantify or objectively evaluate asthma, we follow this pediatric asthma score that gives mild category, moderate, and severe severity. The mild severity scores 1 to 5, moderate 6 to 9, severe 10 to 15. There are 5 components in this asthma scoring system. 1, respiratory rate. It's based upon the age of the patient. The lower the age, higher the baseline respiratory rate. Second is oxygen saturation, whether the patient has normal saturation, room air, or decreased saturation in room air. And auscultation, whether the patient has wheezes, whether the wheezes are expiratory or inspiratory expiratory. Retractions, whether the patient has intercostal and subcostal, or supraclavicular and intercostal and substernal. And dyspnea, speak in sentences, speaks in short sentences, and finally not able to speak. The overall goals of care in acute asthma exacerbation is immediate and objective assessment of severity of acute exacerbation. The prompt and effective medical intervention to decrease respiratory distress and improve oxygenation and appropriate disposition of the patient and safe discharge home plan. Number 1, immediate and objective assessment of severity. The focused H&P is recommended in all acute asthma exacerbation. To confirm the diagnosis of acute asthma exacerbation, determine the etiology, determine the severity, and estimate the risk factors for ICU admission. In addition, one has to ask about previous asthma history, exposure to triggers, asthma medications administered, and how compliant the patient is, and what's the dose of the medication and timing of the medications. Is there any social barriers to care and risk factors for dying from acute asthma exacerbation? These are the list of risk factors for dying from acute asthma exacerbation. Each and every patient who come with exacerbations need to be scanned for these risk factors, like previous severe exacerbation, meaning more than 2 hospitalizations for asthma in the past year, more than 3 ED visits for asthma in the past year, more than 2 canisters of SABA, meaning short-acting beta agonist per month, and difficulty in perceiving asthma symptoms or severity of acute asthma exacerbation, a lack of written asthma plan, and currently using or recently stopped oral corticosteroids. That is the severe acute asthma exacerbation marker. In social history, low socioeconomic status, inner city residents, illicit drug use, major psychosocial problems, comorbidities such as cardiovascular disease, another chronic lung disease, chronic psychiatric disease, and food allergy. Respiratory viral infections are the most common trigger for acute exacerbation. Almost 85% of them are triggered by viral pathogens. Among viruses, human rhinovirus constitutes 74% and the rest by RSV and influenza. There are other triggers needs to be kept in mind: allergens, drugs, exercise, and other environmental irritants. There are three things that happens in the pathophysiology of exacerbation. One, the trigger causes airway inflammation, and the airway inflammation causes bronchiolar hyperresponsiveness. That bronchiolar hyperresponsiveness can cause reversible obstruction initially, then it can become irreversible. That causes air trapping and dead space ventilation. So what are the tests one need to do in exacerbation of asthma? One, the pulmonary function test. In children does not give valid information because they cannot give or they cannot do pulmonary function test appropriately. X-ray chest not routinely indicated, and it is indicated in when the patient comes with first wheezing episode or asymmetric lung findings, and when there is an unexplained fevers and lack of response to treatment, and also when the patient is in critical illness. All patients need to get X-ray chest. Blood gas is not routinely indicated. So whenever you make the diagnosis of acute exacerbation, make sure there are no other underlying disease we are manifesting as acute exacerbation, such as bronchiolitis, anaphylaxis, pertussis, vocal cord dysfunction, heart failure, foreign body aspiration, cystic fibrosis, lower airway mass effects. These are very important because the treatment is completely different. Identifying, for example, foreign body aspirations is to be identified and treated appropriately than the acute asthma exacerbation. It's completely different course. Age consideration also needs to be kept in mind. In children less than 1 year, bronchiolitis is more common. 1 to 5 years, classically underdiagnosed exacerbation or asthma, since they cannot perform pulmonary function tests. And young children with bronchopulmonary dysplasia, cystic fibrosis, and other non-accidental injury also needs to be kept in mind when the patient comes with wheezing episode. In 2 to 15 years, 20% of the children have mycoplasma pneumonia, especially with first exacerbation associated with 50% chance of having mycoplasma infection. In older adolescents, you need to keep in mind smoking, cannabinoids, opioids, withdrawal, and vaping related lung injuries and comorbid mental problems. Clinical pathways for asthma. Clinical pathways is very important for ambulatory setting and also emergency department and in the hospital. These studies, which I am going to show you, they evaluate presence of or established clinical pathway in that setting, how it affects the outcome of the patients. There are studies involving 2,600 participants met the inclusion criteria using asthma clinical pathway to decrease the length of hospital stay. As you can see here, the length of hospital stay decreased in all the studies done, all the randomized control trials done. So having a established clinical pathway definitely decreases the length of hospital stay, and also it decreases additional visits, as you can see here, and as a result economic costs borne by the hospital or the patient will be much lower when you have an established clinical pathway. Established clinical pathway, that means you are already know when the patient comes with mild what to do, moderate, what to do, severe, what to do. If the patient does not respond, how to proceed in transferring the patient or escalating the care, so on and so forth. That also allows the staff is equipped to handle those kind of patients, and also they know when to transfer, when to escalate therapy, so on and so forth. There are 5 sub goals when you treat exacerbation of asthma. 1. Treatment of hypoxemia. Number 2. Early administration of steroids and administration of bronchodilators and administration of additional critical care medications. And most importantly, regular reassessment for treatment response. That is very critical. Whenever you treat the patient, make sure the patient is responding to that treatment. First, tackle the hypoxemia. Hypoxemia prior to bronchodilator treatment is a marker of acute asthma exacerbation severity. The baseline saturation is less than 92 means the asthma is severe and they may need prolonged frequent dilator therapy. Hypoxemia after 1 hour of bronchodilator treatment is a risk factor for hospitalization. So checking saturation gives lots of information about what kind of course the patient is going to have. Second, and most important, early administration of systemic corticosteroids. Early administration of oral steroids within 1 hour of presentation reduces need for ED and also duration of symptoms and also hospitalization. Usually mild acute asthma exacerbation do not need oral steroids. But in moderate and severe exacerbations, oral steroids are strongly recommended. The duration of steroids typically 3 to 5 days. The question is, what kind of steroid should we use? Whether to use prednisone or oral dexamethasone. The advantages of dexamethasone are it is long acting, half-life is 36 to 72 hours. It is 6 times more potent than prednisone. The prednisone half-life is 18 to 36 hours. Dexamethasone dosing is easier, single dose per day. The duration 1 to 2 days with the dexamethasone versus 3 to 5 days with prednisone. And decrease vomiting with the dexamethasone. The next question is whether to give dexamethasone orally or intravenous or intramuscular. Let's look at the studies. Which one is better? There are 9 studies involving 804 participants, intramuscular 402, oral 402 patients. The 4 studies involved children and the 5 studies involved adults. So you can see here the overall response, whether it is oral or parenteral, in this case intramuscular, not much of difference. This one divides children and adults. As you can see, there is not much of difference whether you give intramuscularly or orally in both children and in adults, overall the same. Then they looked at the symptomatology, how it improved the symptoms within 10 days and after 10 days. Within 10 days, the symptoms improved a little favorably towards parenteral steroids. But after 10 days, symptoms are similar in both the groups, both parenteral and oral steroids. The dose of the steroids are as follows. Prednisone, typically 1 milligram per kg, max of 60 milligram. It can be given once or twice a day for 3 to 5 days. But you need to be concerned adrenal suppression, especially when you give steroid for longer term. Dexamethasone, the dose is 0.15 to 0.3 milligram per kg per dose, max 10 to 16 milligram. Dose typically given 1 or 2 doses, typically 1 dose. IV administration is possible, but it is less preferred. Oral dexamethasone associated with decreased vomiting when compared to prednisone. Methylprednisolone often uses in severe illness and in critical care unit. we do exclusively methylprednisolone. The dose is 1 to 2 milligram per kg per day. Max is 60 milligram. It is given every 6 hours for 3 to 5 days. The methylprednisolone has less mineralocorticoid effect than hydrocortisone. Hydrocortisone also can be used in the dose of 5 to 7 milligram per kg per dose, but pretty much in the United States we use methylprednisolone exclusively for this purpose. Then bronchodilators. The first line bronchodilators are short-acting beta agonists. It's called albuterol in the United States. Outside the United States, it's called salbutamol. The side effects are it causes transient tachycardia, tremors, and hypokalemia. In mild to moderate exacerbations, well, what to use? Whether to use nebulizers or inhalers. When you use a metered dose inhaler, it decreases the length of stay, it decreases the pulse rate, decreases the risk of tremors, and definitely major cost savings. And it's very convenient when compared to nebulizer, especially when you are in travel. You have to take the nebulizer and the medications, and it needs to be charged properly, so on and so forth. But when you do a metered dose inhaler, it's much more convenient and easy. The dose of albuterol in mild and moderate categories, 2 to 6 puffs. Mild to moderate, 4 puffs. The patient is less than 20 kg, and more than 20 kg is 8 puffs. It can be given every 20 and every 20 minutes for the first hour, then every 30 to 60 minutes. In critical illness, it is given either every 20 minutes or continuous NAB, 2.5 milligram less than 20 kilos and 5 milligram more than 20 kilos. But in practical perspective, when the patient is severe, we tend to give higher dose of continuous NABs, anywhere between 10 to 20 milligram per kg, not per kg, 10 to 20 milligram per hour. And the intermittent doses are maybe given in emergency department when the patient comes to critical care. You all the way start with continuous NAB. As I spoke earlier, continuous nebulization is preferred in critical exacerbations. Adjunct bronchodilators can be used, especially in moderate to severe exacerbations. The medicine used is called ipratropium bromide, and the dose of ipratropium bromide in moderate to severe is 3 to 4 puffs if the patient is less than 20 kilos. With more than 20 kilos, 6 to 8 puffs. It is given with metered dose inhaler with spacer. It is typically given every 20 minutes in the first hour. In critical illness, it is given via nebulization, 250 microgram less than 20 kilogram if it is 500 microgram in patients more than 20 kilos every 20 minutes for the first hour. It typically loses its efficacy after 3 doses. So most of the patients do not continue to receive ipratropium bromide after 3 doses of initial treatment, most of the time in emergency department. Magnesium sulfate is almost routinely used in exacerbations, especially in moderate, severe, and critical exacerbations. The dose often used is 50 milligram per kilogram that needs to be infused over 20 to 30 minutes. The maximum amount is 2 gram. So when you infuse max sulfate, watch for hypotension. This next subsequent 4 slides, it is borrowed from GINA, that is Global Initiative for Asthma, published this year. These 4 slides are different from the previous year, so I thought I would share this one with you. Number 1, oral salbutamol or albuterol or theophylline is not recommended. In the United States, I don't think it is even available, so we don't use it. Advocate for global access for essential inhaled medicines for all. In fact, it's recommended to give inhaled medication in all asthma patients. In case only oral agents are available in some resource limited areas, please follow this article to find out how to give oral short-acting albuterol, short-acting beta agonist. The next is Gina states home nebulization is not recommended across the board. Home nebulization of SABA, short-acting beta agonists, is associated with increased risk of severe exacerbations, increased risk of mortality, increased risk of transmission of infection. So it is recommended to use metered dose inhaler with spacer. It gives quick relief and less risk of transmitting infection. The third one, they make it what kind of inhaler choice and environmental considerations. Inhaled corticosteroids markedly reduce the risk of asthma exacerbations and death. There are many inhaler types available with different techniques. Some inhalers are not suitable for some patients. For example, dry powder inhaler not suitable for children less than 5 years. Metered dose inhalers difficult for patients with arthritis or weak muscles. The capsule devices are difficult for patients with tremor. Most patients don't use their inhaler correctly. They tend to have more exacerbations. It's very important to choose the right inhaler and the techniques they know how to use it. The incorrect technique, as I said, it causes more symptoms, more exacerbations, and higher environmental impact. The propellants with the current PMDIs apparently have 25 times global warming potential compared with dry powder inhalers. As we stated earlier, dry powder inhalers are not recommended for children less than 5 years. Then inhaler choice. The next questions you need to ask is, first, what is the right medication for this patient? Which inhaler can patient access for these medications? Most of the time it's determined by insurance in United States and outside United States based on the availability. And most important thing, in my opinion, the correct technique how to use the inhaler. Then environmental implications. Manufacturer, propellant for PMDIs, and recycling potential. Consider the patient environmental priorities. Avoid green guilt, which may contribute to the poor adherence, and check the inhaler techniques frequently. Make sure they are using it correctly. Then magnesium sulfate. In severe and critical exacerbation, not responding to albuterol ipratropium bromide nebulization, one should use mag sulfate. It is a competitive antagonist for calcium receptors. The dose is 25 to 75 milligram per kilo, but most of the time it's used 50 milligram per kilo. The max dose is 2 gram. When patients come with severe exacerbations, do not even wait for not responding to albuterol and ipratropium. I think you should start giving mag sulfate. Earlier break the asthma, better for the patient. The side effects of mag sulfate, hypotension and rapid infusion. So it needs to be infused over 20 to 30 minutes. It can cause respiratory depression, facial warmth and flushing, muscle weakness, vision changes, and dry mouth. The nebulized max sulfate has been shown to be ineffective in children, but shown to be effective in adults. I will show the data in another couple of slides. This study shows intravenous versus nebulized max sulfate in acute exacerbation in adults and children. There were 25 trials, it's a meta-analysis, 16 intravenous and 9 nebulized, involving 1,754 patients. As you can see, mag sulfate across the board helps reducing asthma symptoms. When compared to the nebulized mag versus intravenous magnesium, you can see in adults it favors nebulized magnesium sulfate. The next topic is Aminophylline in asthma. Even though most of the centers do not use aminophylline in the United States, it is often used in countries outside the United States. So I like to mention what is aminophylline, what are the effects, and how does it work. It inhibits it inhibits phosphodiesterase enzyme. As a result, it increases CAMP, increases respiratory drive, catecholamine release, prostaglandin antagonism, and inhibition of afferent neuronal activity. The issue with the aminophylline is it has a narrow therapeutic index, like 10 to 20 mics per ml. When it exceeds 20, it causes severe side effects. So I'm going to show the meta-analysis of the effect to show the effectiveness of aminophylline and also the side effects of the aminophylline. This slide shows the effect of aminophylline versus placebo in various time frames, like at baseline, 30 minutes, 60 minutes, 12 hours, and 24 hours. As you can see, aminophylline does improve the symptoms at 60 minutes, 12 hours, and 24 hours. But when you use aminophylline with steroids and without steroids, what is the effect? As you can see here, when you use with steroid, that means aminophylline with steroid, it did not show any significant improvement. But when you do not use with steroids, that means without steroids, and shows some improvement. So overall, so when you use steroids, it's beta agonist, it is as good as using aminophylline. Aminophylline becomes inert when you in that settings. But when you look at the side effects, look at tremor. Tremor is when compared to placebo, of course, and it is more pronounced when you use aminophylline, and vomiting more pronounced when you use aminophylline. Arrhythmia palpitations are common when you use aminophylline. Most importantly, convulsions, even though we do not have enough data to support placebo versus aminophylline, but aminophylline convulsions arise out of aminophylline toxicity is very significant and different. Oftentimes, they are recalcitrant to the anti-seizure medications. That is the reason it is fell out of favor. Number one, it doesn't give enormous amount of advantage when you use beta agonists and corticosteroids, and it has lots of side effects, and it has a narrow therapeutic index, 10 to 20 microgram per ml. On the other hand, we use more terbutaline in the United States. The early initiation of IV terbutaline reduces respiratory failure, reduces ICU admissions, and reduces mechanical ventilation. The side effects are it can cause tachycardia, diastolic hypotension, hypokalemia, transient increase in troponins, and cardiac ischemia. In pre-hospital settings, terbutaline can be used subcutaneously and also one can use intramuscular epinephrine. Another agent often used in patients with exacerbation of asthma is ketamine. It causes bronchodilation by NMDA antagonism. It releases endogenous catecholamines. It causes anticholinergic effects and immunomodulation. The adverse effects are siluria and hallucinations. Hallucinations most often seen in adolescent individuals. In children, I have not seen, but siluria you see across the board. The dose of aminophylline is 5 mg per kg loading dose followed by 1 mg per kg per hour. It's not recommended by United States as you can see here, but it's recommended in other guidelines across the globe. IV salbutamol is not available in the United States. Outside the United States, you can give 7.5 mic per kg bolus over 5 minutes or followed by 1 to 2 mics per kg per minute infusion, max 5 mics per kg per minute. As you can see, it's not present in United States guidelines. Terbutaline, on the other hand, you will see in American guidelines. The dose you give is 2 to 10 mics over 10 minutes, followed by 0.1 to 10 mics per kg per minute. Personally, I do just infusion. I don't give a bolus. In pre-hospital settings or emergency department, one can use subcutaneous terbutaline. The dose is 0.01 milligram per kilo. Epinephrine intramuscular, often used in pre-hospital setting and also in emergency department. The dose is similar, 0.01 milligram per kilogram, max of 0.5 milligram. It can be given every 20 minutes, similar to subcutaneous terbutaline. Ketamine doses 1 to 2 milligram per kilo, followed by 20 to 60 mics per kg per minute infusion. It's often used when you use the BiPAP in patients with asthma exacerbation. Regular reassessment is important parcel of exacerbation treatment. 1 to 2 hours post-administration of short-acting beta agonist needs to be done, and also 3 to 4 hours after systemic corticosteroid administration. Okay, now when to send the patient to emergency department from home? When the symptoms are not relieved promptly with inhaled beta agonists. More than 6 puffs of SABA for symptom relief in the first 2 hours. There is no recovery after 24 hours. That means the persistence of symptoms over 24 hours, immediately they need to go to emergency department. The second question is when to send the patient from clinic to emergency department. Acute exacerbations failing to resolve within 1 to 2 hours despite 3 repeated doses of inhaled short-acting beta agonists. Persistent tachypnea despite repeat SABA, even if the child shows other clinical signs of improvement. For example, if the wheezing gets better, it perked up, but he continued to have persistent tachypnea, they need to go to emergency department. Or when there is a severe or critical exacerbation signs. Lack of capacity for ongoing care in the clinic. Recurrence of signs or signs of severe exacerbation. The patients come back within 48 hours of therapy. They also need to go to emergency department. Or when there is a risk factors for fatal asthma, as we discussed earlier, any of those, they need to go to emergency department. Next question is when to send the patient to inpatient care from emergency department. When there is an ongoing need for supplemental oxygen, those children needs to be admitted. When there is a severe exacerbation despite 1 to 2 hours of continuous albuterol therapy, needs to be admitted. Continued moderate exacerbation for more than 4 to 6 hours after corticosteroid administrations need to be admitted. And when there is a deterioration on conventional treatment, or when there is a social factors limiting the delivery of care like low socioeconomic status or family background, they need to be admitted. Or when there is a risk factor for fatal asthma, or when there is a geographic distance of the patients, the faraway patients needs to be admitted in hospital. Then when to discharge the patient. When the SABA use more than 4-hour intervals after 4 to 8 hours of treatment. When there is an adequate oxygen saturation and room air. When there are minimal signs of respiratory distress. Improved pulmonary function test if capable to perform. Baseline ambulation and drinking. The patient is back to her normal self. And also safe ongoing monitoring at home. Follow-up instructions are very important in managing asthma, both acute exacerbations and also in ambulatory settings. Number 1, they should have written and verbal instruction on signs of recurrence and worsening asthma. Written individualized action plan with details for ED care, a review of MDI and speech technique and medications. This is very critical. Prior to discharge the patient, they should be able to do the right technique to deliver or use MDA with spacer. And they have adequate prescriptions and supplies and the remaining course of oral steroids. And you should have a follow-up with PCP in 1 to 2 days after discharge. And if the patient had a critical exacerbation, they should have follow-up with ped allergist or pulmonary referral. This concludes seminar on acute asthma exacerbation. If you like it, please like it and share it with your colleagues and leave a comments, and we will see you next time. The seminars are conducted every Sunday at 7:30 a.m. Central Time and 6 p.m. Indian Standard Time. Those are live seminars. All the seminars will be uploaded in the YouTube channel American Medicine. Thank you so much for listening.